one of the further analyses that we are presenting at the ASH meeting is actually a pooled analysis of older chemoimmunotherapy trials that were conducted in the German CLL study group. And in this analysis, we wanted to look at the frequency or have a high-level look at the frequency of infections and the outcome of patients who develop infections during or after treatment with chemoimmunotherapy. And so in this analysis that included almost 3,000 patients who received frontline chemoimmunotherapy, we first had a look at how many patients actually develop severe infections, meaning grade 3 or higher infections while on or after treatment. And we saw that approximately 10% of the patients experienced these kind of severe infections, and they were very equally distributed across all different sorts of treatments. So there were patients who received FCR, bendamustine rituximab, chlorambucil-based regimens, and across all the frequency was overall relatively similar when it comes to infections. There seems to be a slight rate of infections with FCR, although the comparisons across these groups is a little bit tricky given that the age of the patients is very different, and the overall cohort was enriched with patients who received chlorambucil. So it was it's one of the pitfalls of these retrospective analysis that the patient cohorts are a little bit different across within this analysis set. We also observed that, interestingly, there was no correlation between the risk factors that we usually understand as potentially indicators of a risk of infection. So the number of patients or the high rates of neutropenia at treatment initiation, or even the rate of neutropenia that occurred during treatment, was not correlated with the frequency of infections, and also the number or the levels of immunoglobulins at the beginning, so before treatment initiation, was also not prognostic of the treatment, of the outcome or the frequency of infections in this pooled analysis, indicating that these parameters, while they can be informative in an individual setting, at least in this retrospective analysis, they did not predict or prognosticate on the risk of infection or developing a serious infection on chemoimmunotherapy. But finally, interestingly, we also saw that patients who experienced any sort of major infection had a significantly shorter overall survival than patients who did not develop severe infections on treatment. So this suggests that patients still that one of the main causes of death and fatal outcomes in CLL still is related to infections, and that therefore it becomes even more important that when we are administering particularly chemoimmunotherapies, that we particularly take care of our patients when it comes to antibiotic prophylaxis and managing when infections occur, managing these according to the respective guidelines, and to really be aware of the detrimental outcome of patients with CLL who develop infections. And so this analysis by far is not completed, so we are still at the moment looking at the old data regarding the use of GCSF and the development of immunoglobulins at the end of treatment or sometime after treatment. So all of these questions, also the use of antibiotic prophylaxis and so on, we are trying to dig this out from the databases that we have in order to better understand how these factors might influence the overall analysis.